Okay. So last week we talked about some of the common presenting problems that women would come into the sex therapy clinic regarding, and this week I'm going to focus on some of the main ones that men might come in for. Again, from as I could say with every single topic that we talk about, a lot of times, unless you're working in a sex therapy clinic, they're not going to come in stating that this is the issue. It would only be if you follow the implicit model and give them permission to talk about these things. So, for example, one of the first ones we should talk about is malerectile disorder, which is persistent or recurrent inability to attain or to maintain until completion of sexual activity and adequate erection. The disturbance causes marked distress or interpersonal difficulties, so that needs to be in place for it to be diagnosed. And the erectile dysfunction is not better accounted for by some other axis 1 disorder other than sexual dysfunction. Is not due exclusively to the direct physiological effects of a substance or a medication. And then I think, just like you would do with every diagnosis, you're going to see, is this something that's always been an issue, or is it something has it been a lifelong issue, or has it been something that has been acquired in a recent period of time that helps you sort of figure out, along with whether it's generalized in all situations or if it's only in certain situations, that helps you determine whether or not it likely has a medical origin versus a relational or interpersonal or individual or origin. So you're going to be thinking about those things. Some suggested steps with this is, again, you must refer to a physician and rule out any non-psychogenic causes or non-relational causes. There's so many different medical issues that can cause erectile difficulties. So you have an ethical duty to make sure that those are not the cause, and to rule out bigger problems that could be happening with a person physically. You're going to explore the context of the problem. You're going to do crucible work about it. You're going to challenge the meaning that they may hold about it. You're going to do cognitive restructuring exercises with them, and you're going to apply your own specific model to it. So don't throw out the models that you are learning, because those can have applications even when you're addressing sexual issues. Okay, just to make you aware of some of the non-psychogenic causes of ED. Diabetes is one of the most common causes of impotence and usually occurs in about 60% of all diabetic men. It's usually related to vasculatory or circulatory changes in the blood vessels. Sometimes, though, the diseases causes damage to the nerve endings in the penis, which can interfere with the process of erection. So this is part of I want you to know about these things, because this is part of how you would do your detective work. If I have a client that I know has diabetes, then I'm going to have the hypothesis that maybe it might be affecting their sexual their sexual experiences. So I want to ask questions about that. Vascular diseases such as arterial sclerosis, the hardening of the arteries, and heart disease are common medical causes of impotence. Stroke can cause vascular damage too. So, and if someone's a smoker or struggling with alcoholism, those are all, again, cues that I'm going to think about and know that I should ask questions about sexual functioning. Multiple sclerosis, renal failure. It could be just, one of the things I want to ask most of my clients is if they're on any medicines, and because lots of different medications can have sexual side effects, including those that are treating depression and anxiety. Alcohol, again, any anti-hypertension medication, antidepressant medications. If they're a drug abuser, I'm going to ask about their sexual functioning. If they've had spinal cord injuries, if they've had an injury to the autonomic nervous system by surgery or radiation. So if someone's going through cancer treatment, then I'm going to ask them about, have they noticed any changes in their sexual functioning. You can see, as we go over all of these, that there's many different things that can affect erections. And so, you need to use the implicit model and give permission for them to talk about it by opening the door, by asking them a question about it. So there's a number of different treatments. I'm going to go through from the least invasive to one of the more invasive ways that this has been treated. I want you to know that even though some of it may be new and may seem extreme, they're there for a reason, and that people are, people's sexual functioning is very important to them, and so don't let your, I want you to be aware of them so that you don't let your surprise at some of these get in the way of them being able to address an issue that they're struggling with. Okay. Well, the first one is like the medical approach to it is using Viagra or similar types of medications. It's a prescription medication for the treatment of male erectile dysfunction or impotence, and it's the first oral medicine that was approved by the FDA. That's been proven to improve erections in most men with impotence. So really, this was a major change because there had never been anything like this before. I was working in the sex therapy clinic at the time, and we really thought like, wow, this is just gonna we're not going to have a job anymore because it's going to address this common issue. That's not the case. We ended up finding out that it just people had adapted their lives, and then all of a sudden they were able to have erections again. So the thought that it was the end of therapy, not at all. If you can't read that, it says, "Doc, can you grant me a prescription for some of that Viagra?" And his partner saying, "Just say no." Sometimes people like maybe for years have had difficulties with this, and so a system or a pattern has developed. So all of a sudden, to have the ability to have an erection again actually could cause a couple difficulties that need to be addressed. So there's that. Another really simple treatment, and some you could debate whether or not it might be even less invasive than taking a medication because it doesn't require you to ingest any medications, is vacuum therapy. So one of the least invasive of all treatment. It also offers a really high rate of success. About 90% of people can do it. It's fairly convenient, at least to satisfaction, and because it provides the ability to initiate and end the erection when desired, people like that about it. The technique works by applying a negative pressure to the penis by placing a cylinder over it and withdrawing the air. Under pressure, blood then flows rapidly into the penis, creating an erection. A tension ring, a little band, is then placed on the base of like a rubber band, but it's a flat one, placed at the base of the penis to maintain rigidity and be left into place up for 30 minutes. Most men, after you sit down and kind of walk them through how to use the device, can master it fairly easy. And the procedure only takes about 2 minutes, so in some ways it could be faster than Viagra, and it can be. You don't want to leave it on for too long, but up to 30 minutes, you could leave it on. That's what it looks like. Now, it's important that they use some sort of lubricant like KY jelly to make the seal complete. And then it's kind of like, you just see that little handle there. You just pump it, and it withdraws the air, and blood then flows into the penis, and then you put the band on the base of the penis. I think if you're going to do this work, it might be useful to have one of these that you could demonstrate to them, or not demonstrate them. I should be careful with my wording. That you could show them how it works. Maybe having diagrams or things like that. Again, it's pretty straightforward. What was I going to say about that? Oh, I know some of you, when I talked about dilators, talked about sending people to a pharmacy. They may have these things at pharmacies, but more likely you're going to find them at a medical supply store. And so, yeah, send them to a medical supply store, or you could have them and then, just add on an extra fee. I think you could do that for the cost of these at your clinic. I don't send them to a place or help them know that there are things that are called penis enlargers, that if they actually worked, they would be multi-billionaires. But they look somewhat like this, but you don't want them to confuse a penis enlarger with a pump. So help them to know the difference between those. Okay. Another one, and this is a very viable option. This is where people start to have their own reaction to it. Is self-injection therapy. So it's a treatment option in which the patient gives himself an injection directly into the base of the penis. The needle is small, similar to the one that's used for insulin injections by diabetics, and the erections are usually of good quality and will last for about an hour, coming and going, so they're not permanently erect. The drawbacks are mostly logistic. Some men are reluctant to give themselves shots. Also, the drugs usually require some refrigeration and mixing and can only be used 2 or 3 times a week and only once every 24 hours. And also, over time, it can lead to a little bit of scarring, which could lead to some damage to the penis. Now, this is really important. Like, you need to make sure that your facial expressions don't make it so that people don't try this, because it's a viable option. And usually it's like they've tried the other less invasive options, and so now they're looking at these. Self-injection therapy has been used since the early 1980s. Several medications are available for that. Some contraindications is hypersensitivity to any of the drugs that are used that might lead to prolonged erections, or if they have sickle cell disease or leukemia or multiple myeloma. And then know that men that are on anticoagulant medications or blood thinners can't use this approach. This is again why you would want to do a sex history to get a little bit of that, and maybe coordinate your care with a medical provider. I would have this diagram so that you could show them about this. Now think about this like it's like someone who has diabetes. Maybe this isn't their ideal, like they don't wish they needed to do this, but it is a treatment option that works. So I would walk through them, and then I think part of our job as therapists is to help them feel okay about it. I was doing a lecture one time, and this participant raised his hand, and he said, "Well, actually, me and my wife use this approach, and we really just incorporated it into our sex play. So she'll dress up as the naughty nurse, and I'll be the patient, and she'll inject me. And so don't underestimate the creativity and resilience of people to be able to adapt to changes in their lives." Okay. So again, my main self as a therapist thing with this is don't let your stuff get in the way of other people addressing their issues. Okay. Now, people say this is more uncomfortable than doing injections, but it is also a viable option. It's the intraurethral pellet. So implantation was introduced back in 1997. It's a small applicator that is used to insert a small pellet of medication into the male urethra, the opening at the end of the penis. And the medication causes blood vessels to relax, and that allows the penis to fill with blood and thereby cause an erection to occur. The erection process usually happens about 5 to 10 minutes following the application of medication, so it's fairly quick. So I want you to know that is also an option out there. And then probably the most invasive is penile implants. These are the most invasive treatment options. So again, you've sort of ruled out all the other less invasive options, but this is also a viable one. Because it's a surgery though, so it's an irreversible procedure. It usually is reserved for situations where other methods had failed. But people do, these are a common thing. If you're working with over time, you're going to meet people who have had this. It's a prosthesis or a penile implant. It consists of 2 semi-rigid or inflatable cylinders that are implanted into the penis, and a pump is implanted into the scrotum, and then a reservoir either in the scrotum or the abdomen exists. But sensation, ejaculation, and orgasm are usually not affected. But because implants are permanently alter the internal structure of the penis, once a prosthesis has been inserted, it's really rare that men would ever have erections naturally. So you want to make sure that it's been addressed, that it's not some other cause. Again, all of these are ones that you would be working in teams with a therapist, with a doctor. I'm sorry, and remember that you have some unique skill sets that and time that you can help people address any sort of psychological challenges that are related to taking advantage of these opportunities. Okay. It sort of looks like this, and I'm sorry I can't come up with a better analogy, but it's not unlike the Nike shoes that had the pump in the tongue of the shoe, and you could just pump it up to make it inflate a little bit. So they just pump it up, and then there's a reserve that lets it go down. Okay. So those are some of the medical approaches to it. But let's if we've ruled out that it's a medical cause and we want to address sort of the context, um, then you think about in what context would a lack of an erection make sense. This is again you doing your detective work. Determine the conditions for having more or better erections. Consider desire, arousal, anxiety, mental and physical stimulation, the time of day, the state of the relationship, the partner's attitude and behavior, and anything else that seems relevant. And it's not just one thing, so you can't just it's not A plus B equals C. Some men need for their partners to be more enthusiastic or aroused. Others need to be less preoccupied and more focused on matters at hand. You got to figure out what is going on and then explore different ways that it could be taking place. Some of the crucible work with this is like, here's an example. So after a busy week recently, I was looking forward to spending some time alone with Paul, time in which we could share a fulfilling, intimate experience. In spite of my caresses and cuddling, however, Paul couldn't seem to respond. He was embarrassed and apologetic. I felt disappointed and, frankly, a little angry. This wasn't the first time it had happened. Sometimes in the middle of intercourse, he would lose his erection and we would have to stop. Once again, I tried to be supportive, assuring him that it was enough just to be together. But really it isn't, and both of us know it. I guess I should just accept it. I would never hurt his feelings by complaining. Okay, so think about what would be the crucible in that. I would think that talking about it directly would be a crucible for this couple. Do you think that Paul knows that she's not happy about this? Like, I believe a basic tenet of therapy is that people cannot not communicate. And when I hear the phrase, I would never hurt his feelings, what I hear is, I can't handle the anxiety about talking about it. It's like it's having an impact anyways. So not talking about it is part of the problem. So you got to challenge some of this meaning that's also tied in there. So what does the lack of an erection represent? One story that a client might develop is, I looked in the mirror and I saw a 57-year-old woman whose beauty was fading, who had gained weight and who was losing the war with gravity. I began to see what I thought was bothering Paul. He was no longer attracted to me. I missed the contact, but was also relieved that I didn't have to feel the rejection of our failed encounters. I began to put my energies into other pursuits, such as family and friends. Okay, so that's just an example. There are often unchecked stories, though. Like, maybe Paul's story is that he's very attracted to her, but he feels shame about that he had a lack of an erection, and now each time he goes, he doesn't want to disappoint her because he's so in love and attracted to her. But each of them, holding the story that they hold, start to distance themselves and get away from addressing this issue. And so relationships die based not on the truth, but on assumptions. Okay. So another thing to you can try is cognitive restructuring exercise. This technique comes from The New Male Sexuality. It's a book you could find in any used bookstore because it was very, very popular. But I'm going to also give you a copy of these particular exercises. But all of you should go get that book. Okay, men and women who have had erection difficulties in their relationship, because again, whether it's whoever's having the problem in the relationship, I am still thinking of it as a couple issue. They tend to say negative things to themselves, and they tend to think of themselves as sexual flops. It's kind of like they're running this movie in their head about losing their erection and tend to ruminate over past failures. So just like last week, I was talking about how a sexual dysfunction develops. There's an initial bad experience. It doesn't go well one time, but there's nothing innately wrong with them physically, because we've already ruled that out. But they start to think about how it didn't go well last time. And then because they're thinking about it, they experience less excitement or arousal. And so then they lubricate less, or they, in this instance, they don't have as strong of an erection. And then it's a reflection of reality, but it also becomes a generator of anxiety, a predictor of future behavior, and a reinforcer of a self-image that you want clients to change. It'll be easier to change their behavior if you also change their view of themselves. So you need to stop that failure film from running in their heads. So one of them is to give them sort of exercises, and I'll attach them that you can look at. You can also do masturbation exercises, and I've attached those. I'm going to ask you for both the recognitive structuring and the masturbation exercises to read through and practice. I think I can't force you all to do it with each other. I just think that would be more ideal than doing it with family members or friends. But if you can't do it, then just read through it. But it would be better if you could practice with one another. Okay. Another common presenting issue besides erection difficulties is premature ejaculation or male orgasmic disorder. The definition in the DSM is a persistent or recurrent ejaculation with minimal sexual stimulation before, on, and shortly after penetration, and before the person wishes it. The clinician must take into account factors such as that affect duration of the excitement phase, such as age, novelty of the sexual partner or situation, and recent frequency of sexual activity. The disturbance causes marked distress. So just because, like, what if you found out that a couple comes in for some issue, but then you find out that their sexual interaction only lasts for 2 minutes? Now you may think, oh, well, that's premature ejaculation. But if it's not a problem for the client, then you don't create it as a problem and it doesn't meet the diagnosis. Okay, the premature ejaculation is also not due exclusively to the direct effects of substance abuse, or for example, the withdrawal from opiates can cause this to happen. Let me just pause and tell a random story because I forgot to say it during the erection part. One of the things I learned about is that one of the ways that people, because they have shame to go and talk to a medical doctor, they try to take addressing the erectile difficulties into their own hands. And one of the ways they would do that is to rub cocaine on their penises, which would lead to an erection. Now, the only problem was that it would lead to priapism, which is when you have an erection for too long. And because they were using an illegal drug, they were hesitant to go to the doctor, to an emergency room, because they didn't want to get in trouble. And because they waited too long, priapism is actually really dangerous because it causes vascular damage to the penis. And so sometimes it would lead to gangrene, which could also lead to people having their penises removed or amputated. So just, if you have someone who's using cocaine, maybe share that story so that they don't experience that problem. Sorry, that really belonged more in erectile difficulties, but I thought you should know. Okay. In what context, just like you would do with every presenting issue, you try and think about what context would ejaculation make sense. I found this once. It seems logical that our prehistoric male ancestors were all rapid ejaculators. The Homo erectus, who could couple quickly with his mate and rapidly reach ejaculation, was then free to deal with enemy tribesmen and predatory saber-toothed tigers. Okay, that's dumb, but I found it and I thought, well, actually, that's not too far off. There's usually some context in which it does make sense initially for people to ejaculate quickly. And so they've trained their bodies to do it. It might be like they started masturbating and they didn't want to get caught masturbating. And so if it ended quickly, then that served a purpose. But then that pattern has continued into their relationships and now is a problem. Okay. I only listed this because this is what it used to be called, which is the other extreme, retarded ejaculation. That's an inhibition of the ejaculatory reflex so that the male is unable to ejaculate either during intercourse or with manual stimulation in the presence of a partner. The more current term is male orgasmic disorder. It's a persistent or recurrent delay in or absence of orgasm following normal sexual excitement phase during sexual activity that the clinician, taking into account of the person's age, judges to be adequate in focus, intensity, and duration. The disturbance also has to cause marked distress, and it's not due to some other factor. Like there are some medications that can also cause this to happen. Again, just like we talked about last week, I'm thinking about how this becomes a systemic pattern. So think about what are the behaviors that a person who ejaculates early or does not ejaculate might do. Like they may avoid, or they may do behaviors tied to depression, or they may do, like, with every couple, you just figure out what one person is doing, and then you'll kind of have some hypothesis about what the partner is doing, and then you could check out those hypotheses. And then therapy really is just getting them to do something different than what the existing pattern is. You're just messing up the system. Okay, some theories about premature ejaculation that if you were to just go and look up all the journal articles on it, here's some themes that you would find. One is that low ejaculatory threshold due to infrequent sexual activity, or it's been called the balloon theory. It's just like they haven't had sex for a long time, and so now it's very exciting because it's infrequent. Some people have talked about cognitive affective factors such as anxiety. So think about that. If a person is just anxious in general as a person, and the sexual experience is anxiety producing, the fastest way to stop the anxiety is to ejaculate, because then the sexual experience is often over. It could be misperceived levels of sexual arousal. I'm going to talk about that in a minute. It could be due to neurophysiological factors such as hypersensitivity to physical stimulation. Some people, just like some people are just more sensitive. So you need to figure that part out. Could be tied to shame, which I think is similar to the conversation about anxiety. It's like, if this is a shameful activity to be engaging in, then the sooner it's over, the sooner I will feel less shame. It could be, and I think this is really common, conditioning from masturbation. Train your body to term. I don't know, my Spanish and English are getting mixed into I can't even think about how to say it in English, but to end quickly. Okay, it could be what I believe, this is my number one, the inability to recognize the premonitory sensation or that moment of inevitability. This is what I think you can use the most to help clients. So think about just the sexual response cycle. There's the appetite, interest, there's the excitement, there's the plateau, there's orgasm, and then there's resolution. What men who ejaculate prematurely is that they're not realizing when they're getting close to ejaculating, and so they're not able to make changes. So threshold awareness, or recognizing the inevitability. They are not focusing on their own sensations, and therefore cannot take appropriate actions. They do not know when to make the adjustment, and they do not know what kinds of adjustments should be made, like in positions or pace. You can help them with all of those. Like there's this moment of inevitability where it's too late. Think about what men often do to try and not ejaculate. They actually go out of their. I mean, you watch any movies about this, if they go out of their mind, they start trying to think about something not sexy. What that does, though, is make them so that they're not tuning into their bodies. You actually want to help them do the reverse of what many people think is common sense approaches. Okay, another really common treatment for this is the squeeze technique, and I've attached a copy of that. So the squeeze action is designed to cause erections to subside, and it can be applied every time that they get close to ejaculating. Your partner can do it, or that they themselves can do it, but your partner performs a squeeze by gripping the penis firmly and pressing with their thumb on the frenulum. That's the place just on the underside of the penis where the head joins the shaft. At the same time, they press on the opposite side of the penis with their forefinger, and with their fingers curled around the shaft. It's important that they press fairly hard, not so that it hurts, but fairly hard on the penis, and doesn't move, and they don't move their hands while doing so. Too light of a touch can cause people to ejaculate. And then I would sit down if I knew that this was something that a couple was working on, and I would present both of this to them and their partner. Basically, it starts at sort of the individual doing and moves up towards being a couple activity. So step one, get your partner to masturbate you with a dry hand. Anytime you get too close to ejaculation, signal for them to stop and to squeeze your penis. As with the start-stop techniques, which I'll talk about, aim to last for 3 consecutive 15-minute sessions before moving on to step 2. Step 2 is get your partner to masturbate you slowly and gently as before, but this time with a lubricant. If you use a lubricant, then it's a little bit more sensitive and exciting. And then just follow the same steps. Step 3 is now you're ready for intercourse, but not for thrusting. Instead, lie on your back and ask your partner to sit on top of you with your penis inside them. Neither of you should move, and as soon as you feel the urge to come, your partner should rise off. This movement is dangerous. I should change that wording, but that's the wording that I got from the new male sexuality book. You're not going to die, you're just going to ejaculate. So this movement is dangerous as it applies stimulation, and then immediately hold your penis in the squeeze grip, and then repeat the exercise for a couple times. It's just you're training yourself to recognize when you're getting close to do something. The squeeze will cause the ejaculation not to happen. Step 4 is when you feel more confident about your self-control, ask your partner to move gently while they are on top of you in the same position. And when you feel the urge to ejaculate, again, do the squeeze technique. There's nothing magic about 15 minutes, but that's like something that you can recommend for them to be trying for. You're now ready to try other positions, but remember, if the man who has the premature ejaculation difficulty is on top, they will have less control. As with the start-stop technique, I'm going to talk about, you should focus on attention on when you're reaching that point of inevitability, when you're getting close to coming. Okay, the start-stop technique is pretty much doing the same thing, but practicing using masturbation. So masturbate with a dry hand, avoid fantasizing, and concentrate instead on the sensation in your penises. You're trying to stay in your body as opposed to mentally out. Allow the pleasure to build up, but then stop immediately when you feel you're getting close to losing control. Relax for a while, still keeping your mind free of fantasies until the risk of ejaculation has passed, and then begin again. Following the same pattern, aim to continue stopping and starting for 15 minutes without orgasm. You may not be able to manage it at first, but keep trying. These are the kinds of instructions I would give them. As you get more practice, you'll find that you have to stop less often. And when you've completed 3 15-minute sessions on 3 consecutive occasions, not necessarily one after another, but then you go on to the next step. And then I'm going to let you all read through this. It's similar, but there are slight differences between this and the squeeze technique. What's similar is it starts at the one where they would have the most control and move towards the one that they'd have the least control in. And so you want them to start with the easiest one so that they have success, and then they move through the process until ultimately they're trying this with their partner and with the intercourse. Okay, so I'm going to stop there, and I'll give you a little bit more detail in below.
You let me desecrate you.